Well, that's our topic for this morning. It's one of those rotating topics that we do an update every so often, and we've got time for discussion or cases afterwards in case anything has changed. Okay, these are our global learning objectives, and here are the session learning objectives to review some checklists that capture clinical and regulatory requirements for an encounter. You know, we like to use checklists in nursing and medicine, and so this is the friendliest way to approach this, I think. Describe a workflow and a documentation strategy that captures those requirements, and that also makes us a clinically useful node. We'll talk a little bit about billing and might have some discussion about different billing practices and reflect on our own workflow practices. You know, I'll find that things ebb and flow a little bit. Some of these checklists I'll be more interested in for a while, and then I'll realize I need to catch up on some other ones. So it never hurts to reflect. When we're thinking about our goals of what we want to accomplish with our workflow, besides just processing the patient through from beginning to end, we have better goals than that. We want to build a relationship with the patient. We'd like our visit to be manageable and stress-free, and that the visit should not be a struggle, because it should be fitting into the scope that we define as what our practice is. As far as MOUD goes, we might think that we're more in a harm reduction type of practice. We might be in a practice where an abstinence goal is really important and sought after, and we want patients to also adhere to that goal. Might be an area where we have more resources, or we might be a psychiatrist or family doctor like me who has additional scope to want to incorporate. And then another goal of our workflow is to meet the regulatory requirements that apply to MOUD in a way that we don't have regulatory requirements that apply to other parts of what we do necessarily. This is the state law, that's the Ohio Administrative Code 4731-33-0103. And you can find it through this link. If you just Google it, it'll pop right up. We can send it as a document also with our resources, but it's just as easy when you want to read it to just get it this way. There are federal laws that also tell us what we ought to do and not do when we're prescribing buprenorphine. So, for example, the law that now says that a non-waivered physician can prescribe buprenorphine for opioid use disorder up to 30 patients is a federal law, not a state law. We really have to stick with the most conservative and the demanding of whatever the laws are is what we have to stick with, and that usually is the state law. We should think of these laws, though, like not as a sort of dry, old, disconnected document that's out to get us or to create pitfalls for us. We should think of it instead as a document that we can work with harmoniously. And what I think we'll see is that just by reading these sets of requirements and thinking about what's clinically useful in them, you know, we can see that really most of those laws and requirements are things that we would want to do anyway clinically, so having them codified that way can actually be useful. It takes away ambiguity for us and tells us that these are the things that we need to do. So you can see the first checklist here is just our personal checklist, thinking about am I in the right situation here to be able to do the kind of prescribing that I want to. And you can see that what I have referenced there in the parentheses is not from 4731. It's a whole different law, because when you read 4731, it'll tell you refer to this federal law that tells you what you need to do to prescribe buprenorphine. And it's pretty simple. We just need to have a valid license as an advanced practice nurse physician's assistant or a physician. And if we are in the waivered route, as most of us are here, we still have the obligation to complete 8 hours of medical education every 2 years related to substance abuse and addiction. I always think that's the most interesting CME. There's not a problem in doing it. It counts towards whatever your licensing requirements are. And that's what we should be checking off for ourselves before we go on to prescribe. We can think about what do we need to do when we're seeing a new patient. And again, like there's a kind of a federal requirement to provide information about all drugs approved by the US FDA for use in medication-assisted treatment. So this is about kind of patients having a choice and not being coerced into treatment. There is a very nice ASAM handout. Oh, I think I could put later. I could put the link in the chat, or we have it to actually send as a PDF, and so you'll get it afterwards. And it just describes buprenorphine, methadone, and long-acting naltrexone, the 3 forms of MOUD, and in very understandable language, so that your patient can take a look and confirm that they really want to have buprenorphine or one of those other ones, and then go to the appropriate place for that. Most of the time, I think when our patients are seeing us, they know that we're prescribing buprenorphine and that's what they want to get. But it is a requirement that they have that review and that we document that they've reviewed the types of MOUD and they've chosen buprenorphine. We might think about also as we're getting our new patient, what the patient's goals and values are and whether they fit or conflict with our program. So for example, if we're working in a program where we really work the best with patients who have an abstinence goal and are committed to doing extra work to be in recovery and to have a good quality recovery that includes managing their mental health and behavioral problems, getting extra medical care that they need. We want to know that that's what the patient wants. If that's not what they want, they're not going to be able to succeed in our program, and they ought to be somewhere else that fits more with their goals. So you all know that when you have a patient and ask them what are their goals, all kinds of things can come up. Often the patient is thinking, I need to get back to work, so I've got to control my heroin use. I just found out I had hepatitis C, and they may care about it or not care about it. A patient may come in already committed to abstinence and already knowing something about the 12-step program and wanting to have that as the frame for their recovery. Or they might come just simply seeking some harm reduction. They're not sure if they want to quit all of their use of different drugs, but they certainly don't want to die of an opioid overdose. And we want to think about whether we can work with that patient from the beginning with the goals that they have. If we've determined that they're okay with the goals that we set in our program and we're okay with what they want to accomplish, then we can get back to 4731. And these letters and numbers in the parentheses are just referencing when you read that law, everything's numbered, and you can go to the section that the checklist references. So this section is about what needs to be included and documented in an initial assessment. So, you know, if you look down that list, there's nothing that would seem really abnormal or out of place. It's all things that we would do anyway. I guess the brief mental status exam, we normally would assume our patient is alert and oriented and able to understand and have capacity. Just documenting that is adequate. Appropriate physical exam might mean different things to different people depending on our scope. You know, minimum is looking for signs of intoxication, withdrawal, or sedation, and then adding whatever else is relevant to where you are. And urine drug screening or oral fluid drug screening has its own checklist. A pregnancy test for women of childbearing age and ability. So that's something to add that you might not normally do in your own practice outside of MOUD. We further want to document that we've looked at an ORS report and describe what's in that. The blood tests that are required to do for a patient entering MOUD are testing for HIV, hepatitis B, and hepatitis C, and thinking about if they ought to be, if they're at high risk for tuberculosis or sexually transmitted diseases. But if you say, normally I would not be ordering blood work and getting it back and interpreting it and so on, there is a kind of proviso here, and that is that if the test is not one of these, the toxicology test for drugs or alcohol that's done through urine, or the pregnancy test is also done through a urine test, then the other labs can be done elsewhere and reviewed by us. So, of course, we're just going to take our own history and substance abuse history, and that's not a problem wherever we are. And we need to have the ability to do those two specific tests for the patient and to include them in their assessment at the time that they're starting the MOUD. But otherwise, if the patient comes with notes, say if they have gone to do some medically supervised withdrawal and then got transferred over to our program, or they got started somewhere else and then came to be our patient, they may have those things already done and recorded in a different medical record. And that is okay to use the physical exam, the lab testing of the patient, as long as it includes those HIV, hepatitis B, and C. We get to decide if that has been done within a reasonable period of time, and then to document that and to include those results in our own note. And if there's any part of that assessment that's not going to be completed before the patient actually gets their prescription and starts the MOUD, we just need to document why that complete assessment isn't done and that we're planning to get it done. So for example, if you have a patient, you're pretty sure they ought to have buprenorphine and you don't want to delay that, it's okay not to have the complete assessment done, but just to document that it's in the plan and then to actually do it. We need to, the 4731 tells us, use an approved treatment protocol. And you will see when you think about what you're doing, if you kind of compare it to one or the other of these, you'll likely see, yeah, this is where my own practice fits in either the SAMHSA treatment improvement protocol or the National Practice Guideline for the use of medications in the treatment of addiction involving opioid use. So SAMHSA produced one, ASAM produced the other one, and those are really the standards of care. So we do want to document that we're using one or the other. I think for me, when I got most of my patients, what was in use was the SAMHSA protocol. So that's how many of my patients started. The ASAM protocol was just updated in 2020. And I think it's a little easier to understand and follow. So you can check on these links and see which one you're using. Making a treatment plan has, again, certain requirements for what we would do, where you think, well, I'm a physician or I'm a nurse, I know how to see patients, I'd be doing this anyway. And these are what they are. Our rationale for selecting a specific drug to use for MOUD, methadone, long-acting naltrexone, or buprenorphine. And it's often that the patient selects that medication, wants to use it, it's within the scope of our practice, and that's what we're going to prescribe. The patient education can be done just by using that ASAM 2-page handout so that the patient's making an informed choice. the patient is going to have an informed consent that often is in the form of a treatment agreement. Need to have that. We need to agree that we're going to do random drug screens, and then a plan in Ohio to adhere to the Ohio law. We do need to have a plan for psychosocial treatment, and we'll get more to that in a moment. Thinking about drug screening, the permitted methods are urine, oral, and serum. So we want to know that we're using a permitted method. Urine is the easiest to do, and I think generally the least expensive. And minimum frequency initially was not specified, so it was a little vague, and now is pretty well specified that if the patient is in the first year of treatment, twice per quarter. So out of 3 months, they should have 2 tests, and once per quarter thereafter. It's a random requirement, which means to find some way so that it's not absolutely predictable when the patient is going to get that test, when you're going to be looking at it. So, you know, for my quarterly patients, I'll pick one of those months and I'll do the test when I'm seeing them. They don't know which one it's going to be, and that to me requires that meets my sort of sense of what I want as a random test. On the other hand, if a patient is having trouble and struggling, and I think something's going on that we need to talk about, I might assign them to come for a separate random test at a different time. So these are minimums, and we can use our clinical judgment about when we want to get more tests than what's required. Am I documenting results? And also, if we have an abnormal result, am I documenting any changes to the treatment plan that I'm making to respond to that result? The psychosocial treatment list is Section E. It's different in Ohio than it is in other states, and maybe sort of subject to change over time. But right now, here's what it looks like. We have to think, first of all, am I myself a board certified addictionologist, addiction psychiatrist, or a psychiatrist of any type? The answer is either yes or no. And then I'm thinking, if I'm within that group, can I determine and provide the optimal type and intensity of psychosocial treatment the patient needs? And it's okay to say, well, no, not really. That's not normally within my scope. So if the answer is no, and this second thing is a little bit of a kind of an escape clause here, that if you're not in one of those groups, but you still can do this other stuff, determine and provide the best type and the best intensity of psychosocial treatment, and then provide that, say, as a